Hello, I'm Norbert Gleicher, MD. I'm the Medical Director and Chief Scientist here at the Center for Human Reproduction, and it is my pleasure to have with me today, once again, both of our Davids, David Albertini and David Barad. David Albertini used to be our Director of the Laboratory Division, but is now back in Boston and a visiting senior scientist here. And David Barad obviously also does not need much introduction. He's in charge of our clinical IVF program and directs our research effort here at the Center for Human Reproduction. And today we're going to talk a little bit about embryology and laboratory in general. And we'll start with some preconceptions that may be a little bit off about what is happening in embryology laboratories. And maybe one thing I can start with is what's in the news. And in the news, there are always errors that are happening in laboratories and concern about potential errors, mix-ups, etc. We addressed that in our voice not too long ago, but I think it's an important subject addressed to the public, making the point that what happens to every gamete, to every egg, to every sperm sample, to every embryo is, in good laboratories at least, very tightly controlled, meaning there are always four eyes on every transaction, so it is never one person alone who verifies things. There's double and triple checking for everything. And therefore, fortunately, these errors that always make the headlines are incredibly rare. I think that needs to be re-emphasized. Nothing is as tightly controlled in a good IVF clinic as the handling of egg, sperm, and embryos. So if anybody out there has any worries, I can tell you that if you're going to a good IVF clinic, your gametes and your embryos should be very, very safe. Other issues that we want to discuss, David,
Sure.
What would you suggest?
I think, one of the things that we often hear from patients is what is it that we can do in the laboratory to, really identify, especially in these days of single embryo transfer when possible. Are there things that we do in the laboratory that can guide the selection of potentially the best embryo, or the embryo with the most potential to possibly implant and lead to a baby? And historically, I think our field has looked to different ways to evaluate. Fertilizing the eggs, of course, the first thing we look for is successful fertilization. But over the years, besides looking at the embryo and the pace that it's developed at, we have seen many technologies introduced that we had hoped would be truly indicative of the developmental potential of the embryo.
But that is the concept of embryo selection.
That's right.
And we all participated in a paper that was recently published in one of the Human Reproduction journals, but we are actually making the point that was probably the biggest waste that has been happening since the inception of IVF, because so many resources have been going towards the concept of finding the best embryo.
To be
Right.
fair,
Right.
when we began IVF, we didn't have freezing. And so when we didn't have freezing and the other embryos were going to go to waste, it made sense to try to select the embryo most likely to succeed. But today, selection depends on a cohort of embryos that you will either transfer or freeze. And really, we just have to identify those that are viable and good enough to freeze.
Right.
And then ultimately, you're going to get, you're going to rank them in some way, but you're going to, the cumulative pregnancy rate is determined by who you have.
That's the, I think, the basic point that is so frequently misunderstood out there, even by colleagues who think that, okay, you do an IVF cycle and you get a certain number of eggs and you get a certain number of embryos, and there must be one embryo amongst those which is the best one, or there must be two which are the best ones. And it's kind of a ridiculous concept, especially if it means spending efforts in finding them or spending money in researching things that will do it, because the cumulative pregnancy chance is determined once you have eggs and embryos.
I mean, ultimately, as David can tell us, based on morphology, you're going to get 95% of the information.
Right.
And all these other things that people are doing with AI, with PGT, with all these other things, maybe adding 2 or 3% on top of that, which really doesn't make any sense if you've got a handful of nice looking morphology.
And I think that's where we're at this point. I mean, if you look back over the past 12 years, these things like PGT-A, okay, like measuring metabolism in the medium, okay, and now morphokinetics, which was the introduction of making movies of embryos as they went through this, and it was always thought, oh, if you develop fast, then you must be the better one. And in the end of the day, none of this has improved pregnancy rates. None of these techniques have really enhanced our ability to select the right embryo. And as you mentioned before, they're not free.
No,
Applying these techniques has added an additional financial burden to our patients.
not only to our patients, but to the whole field. When you think how much research effort and therefore research funding has been spent over 40 plus years since IVF exists on this subject, I think it's probably a majority of all research, because whatever you look at, it somehow is related to the concept of embryo selection. It's crazy. And what we haven't said yet is, since 2010, pregnancy rates not only haven't improved, they have actually been declining. So patients pay more today than in 2010. We have spent a fortune on this concept. Imagine if we could have put all of those resources into something else.
And in deference to the president, this is not NIH-funded research. This is research that adds to the cost of patient care that's coming out of our patient fees.
Yeah, absolutely. Absolutely. Yeah. David, David number 1 or 2, I don't know anymore. But David, you just finished a very interesting study that is going out for publication today, I understand, in which you made some very interesting findings regarding PGT-A in older women. You want to give us a quick summary here?
Yeah. Recently, or over the last few years, people have been doing large analyses, even some randomized controlled trials of the effectiveness of PGT-A in enhancing cumulative pregnancy rates or pregnancy rates in general. And across the board, whether it was a retrospective study or a randomized controlled trial, nobody's been able to show that PGT-A has improved pregnancy rates in young, healthy women. But in many of these studies, it appears that people who have PGT-A, when they're older, have better pregnancy rates than those who do not have PGT-A. And so I'm kind of came to science as an endocrinologist, but also as an epidemiologist. And one of the things you have to ask as an epidemiologist is the effect that you're seeing, the effect of that treatment, or the effect of some association.
Usually patient selection, which is the biggest influence.
Yeah. Well, I'm saying, but is there an associated factor that is actually causing this benefit? And so we had access to national data from the Society of Assisted Reproductive Technology, and we looked at cycles from, I think it was 2014 to 2021. It was like 258,000 cycles that we were able to look at. And what we found is that in the older women who were going through IVF, those who had PGT-A were selected for PGT-A because they had better ovarian reserve. And we looked at several different indicators of better ovarian reserve. And so the possible explanation, or the likely explanation for why in older women, those with PGT-A were more likely to get pregnant, was that they actually had better ovarian reserve, which is why they were able to have PGT-A.
Which is what, when you would just start from zero and start logical, is what you would expect, because older patients, since they produce fewer eggs and fewer embryos, would be the last ones who you would expect to benefit from PGT-A, you know?
So for instance, in the clinical sense, if somebody has only one embryo, they're not likely to elect to do PGT-A. It doesn't really make any sense. They just have to transfer. Somebody has 10 embryos, they might choose to do it. And so that's actually what clinically appears to be happening.
Yes, so that's why it seems so ridiculous when suddenly in the last year or two a few papers appeared making the point, okay, PGT-A doesn't work in young people where we all thought maybe it is working, but it is working in older patients. Everybody started scratching their heads and said, where is this coming from? And it was really your statistical analysis that I think finally confirmed what we suspected, that it is a bias in the patient selection.
It's also it's not just bias in the patient selection. Isn't this also reflecting human biology?
Yeah.
In that you can't age match and predict, because women have different ovarian ages, okay, relative to their chronological age. So you can't just say, oh, if you're over 40 years old, then you're going to have a poor reserve and therefore not many embryos. So.
Yeah, but this kind of quote-unquote discrimination does not only apply to PGT-A. I think this is a discrimination that our field in general has been suffering from a long time, because most IVF clinics treat 25-year-olds with protocols that are identical to 42-year-old women. And that doesn't make any sense. Right?
We had a patient just the other day who went to somebody for a pre-conception counseling, and they told him, don't waste your time doing IVF because you're 40 years old.
Yeah. Yeah. Okay, I think that was an important subject. What else is controversial in the laboratory?
Well, there was the question of the refreezing, if you'd like to, continue this, because as you pointed out before, in the old days we didn't have embryo cryopreservation to rely upon, nor were we maybe as good at collecting as many eggs and making quite so many embryos for patients, that, especially those that were good responders. So along came the wonderful world of cryopreservation. It has changed the face of reproductive medicine for oocyte donors as well, but certainly for having the opportunity to store embryos from a cord gives the patient more and more opportunities to finally have that magical hit, finally have that pregnancy. So now we find that there are situations where clinics will thaw out a certain number of embryos, maybe retest them for PGT-A, etc. And embryos are being subjected to freezing multiple times. And this question has come up. How many times can you freeze a human embryo before you begin to compromise its developmental potential?
Yeah, and for the first time we have seen now one or two studies addressing this, and they are really uniformly demonstrating that every time you freeze, you lose.
Yeah.
And who is surprised about that? I always tell patients, the simple fact, and you don't need to be a scientist for that once you freeze and thaw, some embryos will not survive, or some eggs will not survive. That already tells you that statistically there is a loss every time we freeze. And that is, again, one of those make-believes in our field where suddenly somebody came up with this idea that freezing is a good idea under certain circumstances, for whatever reason, not recognizing that the mere fact of freezing cannot be a good idea unless the alternative is worse. If you have too many embryos to transfer, obviously you're not going to throw them out, but you will freeze. But to voluntarily freeze never makes sense.
Right. Well, there's no, I mean, as being trained in the science of cryobiology for many years, I can tell you that it's not a surprise that whether you're freezing eggs or embryos, that they don't all survive is one thing, but many of them will survive, and you try to create a pregnancy out of them, and they're still not able to do that because there is chemical toxicity in the very formulation that we use, and this is an added stressor already on the cells of an embryo.
To give a clinical example, there are people who have tried to make the argument that when you do a fresh IVF cycle, and even if you have a few embryos, you should freeze the embryos and do the transfer in a later cycle
Yeah.
because you can have a more physiologic
Hormone
level
level.
of estradiol.
Yeah.
I mean, people have actually looked at that in large randomized controlled trials, and there's no difference.
Actually,
there can be a decrease,
there can be a
but
decrease,
there's no harmful effect
Yes.
of doing a transfer in fresh cycles.
Yes.
And in fact, it can be an
An
advantage.
advantage.
If you only have a few embryos, there's no reason to subject them to the
freezing.
hazard of freeze and thaw if you can do a fresh transfer.
Since we don't have much time left, related subject, day 3 versus day 5 transfers. David.
Well, if you only have 3 embryos, 2 or 3 embryos on day 3, we would prefer to do a day 3 transfer of maybe 2 embryos. The continued culture is also a
Selection.
It's a
Process.
selection, and it's a hazard of sorts.
Yes.
There is the best laboratory is not going to be as good a place to incubate an embryo as a human womb.
Right.
Yeah.
And so I give the example to people, if I had 5 kittens and I wanted to know which one to keep, I could keep them outside on February, and the one that survived, for 2 more days.
You are cruel.
But that's what you're doing. You're keeping these embryos in a less favorable condition.
It's not a bad metaphor when you
Yes.
think about it, okay?
Yeah.
Because we do understand that from a physiological point of view, human embryos that are fertilized in vitro, that as a result of in vitro fertilization, have much more stress because they're in an unnatural environment, okay, than those that would be developing, as you say, in the cozy confines of a womb, okay? It's just a totally different environment.
Yeah, but we have been fighting many of our colleagues on this subject who have made the unsupported argument that an embryo that doesn't survive in the laboratory between day 3 and blastocyst stage will never give you a pregnancy. Now that has been, in the meanwhile, shown to be incorrect. While it is probably true that most of those embryos that don't make it to day 5 indeed will not give us a pregnancy, and that's why that is, in a way, an embryo selection process. There are some that will. And
they have a better chance in a womb than they do.
Absolutely,
Right.
absolutely. And this is also the reason why now there are some, once again, cumulative embryo studies that show that there is, if you look at cumulative pregnancy rates, no dramatically different cumulative pregnancy chance between day 3 and day 5. But if there is a trend, it's actually in favor of day 3.
Yeah.
And if you think, again, if we're talking about cost, how much more expensive it is to culture for 5 days than for 3 days. And if you look at this on a national scale or an international scale, you see how much resources we are wasting in IVF for nothing. You know?
That's true. That's true.
Okay,
Yeah.
I think we have covered a lot of territory here today. Thank you very much, and thank you to listening.